Welcome to Raw Online. So today we have a very important topic, the myasthenia gravis. Okay. So I have a question to you friends. So how many ischemic stroke have you seen in your ER and how many myasthenia gravis patients have you seen in your ER? Okay. The incidence is going to be very grossly different, right? There will be a significant amount of ischemic stroke which are presenting to your ER and very remote or very rare is going to be the myasthenia gravis. Okay, so now let me give you a case and you tell me what is your initial diagnosis is. Okay, you receive an elderly male who is very drowsy, weak, and he is brought to your ER. Okay, so you are going to assess the patient is not able to open his eyes. So in your GCS score you are going to give E1 because he is not able to open his eyes. Okay, and in verbal response he is not able to pronounce any words, only sounds. Okay, so you are giving V2. Okay, and he is not able to lift his limbs, only weak flexion he is able to do, right? So you are giving around M3, right? So E1, V2 and V2 to 3 or M3. So somewhere around 6 to 7 is going to be the patient GCS. So what will be your diagnosis, dear friends, in your ER? Okay, routinely if you see this kind of cases, most of the time your diagnosis is going to be ischemic stroke, right? But remember, even myasthenia can present this way. Okay, so most of the cases of myasthenia can present this way and you could have misdiagnosed the patient as ischemic stroke because the eyes will not see what the mind does not know, right? So usually what we'll do, you'll do a CT. If there's a facility, you'll do a CT and CT could be normal because this patient is a myasthenia gravis, right? So you will still stick on to your ischemic stroke protocol and you might end up doing a MRI stroke protocol, right? In MRI protocol, usually it comes to be again negative or some chronic ischemic infarct could be there because it's an elderly male, right? And most of the time in most of the hospitals, when you do MRI, the report will not be available immediately. It will take some time, right? And still if the patient GCS is low, you might end up doing an LP and going on with that, you will even miss out a myasthenia crisis at the best, right? So in your differential diagnosis, you should know how a myasthenia usually presents, how the myasthenia crisis usually presents, how can you differentiate this from an ischemic stroke. Okay, to put it another way, dear friends, the presentation of myasthenia gravis is one of the very common case in your emergency department. It is just that you think of ischemic stroke, the public knows more about an ischemic stroke. So we are leaned towards identifying an ischemic stroke, differentiating an ischemic stroke, and we are forgetting about myasthenia gravis. Okay, so in our seminar, we are going to tell you about myasthenia gravis, the presentation, how you can differentiate this from an ischemic stroke and how you can proceed further. Okay, let's start. Myasthenia gravis. So understand myasthenia gravis is basically an autoimmune disease, okay, characterized by muscle weakness and fatigue. Okay, and it made worse by repetitive voluntary movements. So usually if you see at early morning after a sleep, the patients might have more power in their muscles. But as the day progresses, as the patient is using the muscles repetitively, the weakness is more pronounced. Okay, that is how the patient's presentation will be. Okay, so what exactly is this myasthenia gravis is? There is a nerve. Okay, so there is a nerve, right? There is an end plate and there is a muscle here. Okay, at the muscle region there is a receptor. Okay, there are some antibodies produced against this muscle acetylcholine receptors. So there are some antibodies produced against this muscle acetylcholine receptors. So when these receptors are damaged, any stimulus given by this nerve towards this muscle will not be conducted. So there will be poor muscle contraction, thereby poor muscle movements. Okay, so this acetylcholine receptor antibodies impair receptor function at the neuromuscular junction. This causes muscle weakness most often in the proximal muscle groups. Okay, so imagine that you receive a patient, you're asking him to lift his limb, he's not able to lift his limb, and you coin him as CVA, ischemic stroke, right? So this can still be a myasthenia gravis. I'll tell you how to differentiate this from an ischemic stroke as well. Okay, weakness is generally reversible in a short term by rest. Okay, if the patient rests, the weakness slightly improves. Again, by repetitive movements, it gets worse. Of course, this is amenable for immunotherapy. The early recognition and aggressive management of cholinergic or myasthenia crisis is actually required. We will see what is this cholinergic crisis. We will see what is this myasthenic crisis as well.